good? I think you got something right here. Gotcha. All right, welcome to episode 3 of Vital Conversations. My name is Dr. Mike Shadow,
I'm Dr. Colin Butler.
and we are Vital Performance PT. Today, what are we talking about, Dr. Colin?
All about pain.
Explain pain. I like it. So some of the things we'll talk about are what is pain, how is it useful, when is it not so useful, and some helpful guidelines to help interpret aches or pains that you might be experiencing, and figuring out whether or not the pain that you are experiencing is something maybe to be worried about or contact someone about. So, what is pain?
So I pulled out my phone to Google, since this is where we go for information now.
Love it.
There's two where it's a noun, all right? The first one is physical suffering or discomfort caused by illness or injury. Example, she's in great pain. Also says to associate it with agony or suffering. Second one is careful effort, great care, or trouble. She took pains to see that everyone ate well. Or the verb, cause mental or physical pain too. It pains me to say this. Do you think that any of those really completely encapsulate how we help people with pain as a physical therapist?
Probably not, no. One thing I did notice is when it had some synonyms, there were definitely words that attach like an emotional aspect to it as well. That's where if we decide to go down that rabbit hole, how pain, there can be a psychological factor to pain.
Yep.
And why it might be difficult to get rid of long-standing chronic pain, stuff like that.
So this is the definition from the IASP. Can I first find what the IASP stands for? It could be the International Association for the Study of Pain.
You convinced me.
So when is it from? This is from 2021, all right, relatively recently. And they define it as an unpleasant experience through your senses and emotional experiences that's associated with actual or potential tissue damage or described in terms of such damage.
I like that definition better.
I think that's a little bit better, all right? I think we can simplify that experience a little bit and say that you and I can converse in languages through physical touch, right, through looks and glances. Your nervous system can communicate with you through sensations, right? So I would say that almost always pain is a request for attention or change.
That's probably my favorite definition so far.
I don't think Merriam-Webster got the job done.
I agree. So the way that I'll typically tell my clients to like think of their pain is kind of like think of it like a warning sign or literally what you said. It's your body's way of communicating that you just need to direct your attention to it, because sometimes pain can be useful. So if you step on a nail and maybe you didn't see it and all of a sudden your foot starts hurting, that's your brain's way of telling you, hey, look down at your foot right now. I think there's something impaling your foot. Yes, it could be very helpful in that sense. Is there any?
You touch a hot stove, right? Pain is limiting your ability to hurt your body by making you quickly react, sometimes reflexively. We can talk about how people that don't feel pain have a very dangerous condition.
There's a movie about a guy that doesn't feel pain.
Isn't it on Netflix right now?
It's on Prime. I think Prime. Oh shoot, what's it called? It's the guy from The Boys, the one that doesn't have superpowers.
Yes.
He's in it. It's pretty. Don't watch it with your kids for sure. But like,
adult movie.
Yeah, literally. I think at one point his forearm was fractured, and he used his forearm to the bone sticking out to stab someone else. Literally grabbed something scalding hot out of like a fryer and smashed it over a guy's head to save himself from a situation where he was going to die. Pretty crazy. In that sense of pain as a warning sign to divert your attention to something that could be causing your body physical harm to your body, pain is very useful in that sense.
Yep.
Anything else useful wise, or should we go to when pain isn't as useful?
So well, we defined it. We talked about what it does. It's a communication through your attention or to ask for change. It can highlight damage, right? It can highlight, when we say tissue, that's just all the different things your body is made of, right? There's muscle tissue, there's skin tissue, there's bone tissue, nerve tissue, cartilage, connective tissue, right? Tissue is just a catch-all word for the stuff we're made out of, right? The different components that's in us. All these components have different kinds of receptors for sensations that go into your brain, but it is ultimately your brain that gives that pain meaning, right? That ascribes meaning to it.
So that could be the difference between a sharp stabbing pain or just a mild ache or discomfort, right? So I think we actually used an example of this in the last episode of if you're sitting on a hard surface, if you're sitting on a bleacher at a sports game, or you're in church sitting on a wooden pew, there's a ton of compression right around at your butt, right? And it's creating this environment where you're starting to lose oxygen and blood flow to the area, and there's a ton of compression against those nerves. Nerves do not like being compressed, and as soon as they start feeling compressed, they're going to start sending that signal to the brain to start experiencing some type of symptom to divert your attention to it.
Yep.
And so in that sense, you're not causing any damage. If you just
Right.
shift over, pain goes away, right?
So we've talked about pain's ability to get your attention, all right? But then one part of that definition from the IASP, which was the potential to cause tissue damage, is interesting because there are some great stories from probably the most famous pain researcher in the world, Lorimer Moseley, that are actually personal stories from his experiences of when he actually had an injury that he didn't feel, and because of his experience with that, his body had reflexive, very painful responses to other inputs that were not injury causing. That story with him in the bush, and
I don't
he gets
think
bitten by the snake.
Oh, I know. I didn't read that one.
So, quick analogy. This guy is Australian. His company is the NOI Group. I believe him and Adrian Liu. But as Australians do, he's out in the bush with some friends. The bush is a term for just the wilderness out there, right? And he's walking through some shrubs, right, through some foliage, and he feels a scratch on his leg. And he associated it to the branches or the twigs that were in the bush he was walking through. He didn't think about it. His leg starts to bother him a little more, and he looks down and sees that he has puncture marks on his leg from one of the most venomous snakes in the bush. We will get the name of the snake. We will put a picture of the snake in the show. He immediately starts to having excruciating pain. He has to go to the hospital. He has to get antivenom. He recovers because he was alive to tell the story, obviously. But a couple months later, he's back out in the bush. He's walking with friends again. He feels the same kind of scratching sensation, instantly has the same excruciating pain, but he looks down, there's no puncture marks. It was actually just a branch scratching him, right? So to me, this is a really powerful story about how our perceptions of things can ascribe meaning to pain and can influence the response beyond just the potential for tissue injury.
There's the other story of the guy that I think he was either just walking through a construction zone or he fell from a height or something. And he watched as a nail went completely through his boot. And so the sharp end of the nail was literally sticking up towards him. And he saw that, was screaming in pain. It was intense agony. They rush him to the hospital and they end up cutting off the boot to find that the nail actually never even touched his skin. It actually went through his toes or something like that.
Yep.
But no tissue damage whatsoever, yet he was still experiencing that intense pain.
He perceived a threat, right? He believed himself to be injured, and the amazing orchestra that is how your body feels things and puts meaning to things made him feel agony, right?
So it's not.
I would say that's an example of when pain's not useful.
So it's not just the sensations from the nerves throughout the rest of our body. There's also this psychological component and that perception component that can contribute to whether or not you experience pain as well.
Yep.
So let's actually, honestly, this might be a good segue to start talking about central sensitization and chronic pain syndromes and stuff like that. So I've heard this story from quite a large number of the clients that I've worked with where they've been dealing with an issue for a very long period of time, years, decades. Yeah. And now, back when the pain first started, they very likely did have some kind of injury to some tissue, yep. Whether that was a disc bulge, disc herniation, literally anything. But however, that tissue healed. Our body, it has an amazing capability to heal an injured area. Yet, despite that healing that occurred, these clients still experienced significant levels or intensities of pain for years, if not decades. And so, do you want to go into what central sensitization is or how it occurs?
So I believe I said earlier that there's all these different receptors that are in your skin, in your joints. They can detect heat, they can detect pressure, they can detect chemical changes at the level of the cell, or the neuron is the functional unit of a nerve, right? There's all these different receptors that receive things, right? That information then gets transmitted up from, if it's my arm, up here, through this, into my neck at the level of my spine. The spine then takes that information and sends it up the brain. So when we use the term central sensitization, the central part typically means the spine, all right? Or even the brain, all right? This phenomena is just when there are actual changes that happen to how reactive the neurons are, to where it can take less input to cause the neuron to fire, to send a signal. If you happen to fall down a rabbit hole of reading about pain, sometimes some of our patients have had pain for a long time, you will see the word nociception. The word nociception is meant to talk about the transmission of pain signals. Think about this. Let's say it took, because when you look at the study of this, it's typically the amount of electrical current that it takes, since your nerves are electric. It's the amount of electrical current it takes for the nerve to fire. If it used to take 150, now it takes 60, 70, 50, 40, right? Sometimes these changes can happen if an injury, if the initial bout of the injury persists for a certain amount of time. So now your broken bone has healed, right? Your disc herniation has healed, because turns out disc herniations are an autoimmune issue. It's a function of the immune system to sometimes resorb the disc on its own.
Pretty rad.
It's pretty crazy. For some reason, the barrier for the painful signals to be sent has lowered, and that signaling can still be happening.
And that
Right.
very well could be a learned behavior, like a survival kind of thing. So if you touch, so story time of when I was younger, my dad used to iron all of his clothes. And so me at 4 or 5 years old would watch him iron the clothes, and I never got to touch the iron. And he always said, "Do not touch the iron. It's hot. Don't touch it."
What did you do?
And as soon as he walked away, put my hand to it, ended up with really bad blisters all over my hands, screaming bloody murder. And since then, I learned from experience I should not touch an iron while it's hot, or that could happen again. So I experienced a sensation, had a negative experience because of it. That was pain and blisters, having to go through that healing process. And now I know, on a conscious level and an unconscious level, to
Your body
where
learns to
hot
predict a
surfaces.
response.
That's a better way of saying it. Yeah.
The term predictive processing gets used a lot in chronic pain,
Mhm.
right? Think of the story we told about the guy in Australia, Mr. Mosley, right? His body predicted that scratching sensation was a highly venomous snake biting him, so that he felt it again, right? And had that instinctive reaction.
Yeah.
People in car accidents, right? Say you had a car accident at a certain traffic light, right? Years later, you might drive up to that light and experience some of the same sensations that you felt in the accident: extreme tension, fear, sweating. Pain can be a learned prediction for things,
Yes.
right? Which is often why we get some patients who have maybe learned some unhelpful stories or unhelpful ways to think about their experience with their injury or their condition.
Definitely.
And part of what we get the honor of doing is helping people to change their understanding of their situation and create a prediction violation, right? Or an expectation violation around things.
I like that. I like that. Another useful kind of analogy with what you were talking about earlier about how if it took X amount of stimulus of an electrical current to activate a nerve receptor, and then after you experience injury to a tissue, now it takes less for that pain signal to come on, right? Think of a smoke detector in your house. I've had, so the primary role of a smoke detector is to detect smoke, right? And so if there's a fire in your house, it would be very helpful if that smoke detector were to start going off to let you know, oh my God, there's a threat in my house to my survival. I need to get the hell out, right? Versus having a really sensitive or touchy smoke detector that I've had this in a few of my houses going through college, where I'm cooking something, and sometimes I've had one smoke detector where as soon as I throw something on the stove, that smoke detector will start going off. Or let's just say I get distracted, I'm cooking something, and I go into the other room, handle something, and my food starts to burn a little bit, right? And so there's a little bit of smoke coming off, but not a lot where there's an actual fire in the house. It's not spreading anywhere. There's no present danger threatening my life. That smoke detector is still going to go off. And that's what can happen when someone initially experiences pain, but still has those painful sensations going forward with things that aren't actually causing tissue damage, yet it's still painful. You're not causing more damage in those cases. It's just that your nerves are a little too excitable, and we need to get them reduce that threshold for that pain to come on.
Yep. And there's a lot of ways we can do that,
Mhm.
right? I'm trained to do what's called dry needling, which is the use of the same needles that are used in acupuncture. There's some cool research that shows that dry needling different areas can reset local central sensitization.
Yeah, it's pretty
Right.
cool.
So there's some physical manual therapies that we can help with that in the short term, right? I think the biggest way that we change that with most of our patients is through what's called graded exposure. Right.
And what is graded exposure?
Graded exposure is the concept of we can identify through movement of your joint or through your tolerance for different movements and exercises the amount of a thing that tends to create a painful response. Graded exposure is the process of titrating up the dose of exercise like someone would titrate up the dose of medicine so that you have a tolerable amount of symptoms and your recovery from those symptoms happens at a frequency or a rate that is good.
So essentially, let's just take a back squat, for example.
Yep.
So let's say if we were able to work up to 135 pounds on the back squat, and that's where a client starts experiencing pain. How would you utilize graded exposure in that instance?
Yep. So graded exposure in that instance for the 135-pound back squat, that once we hit that, no matter the amount of reps we do, the tempo we do them at, right, they have symptoms. Immediately, we would probably change the variable of reducing the load. Have people perform a higher volume of reps. When I use tempo, the speed of execution of the movement, right?
So going slower on the way down.
The time hold at the bottom, the time up, the hold at the top. You can change the range of motion of it at that weight that's sensitive. See if it's a range of motion variable at that load that could be causing the symptoms, right?
Mm-hmm.
And then over time, we can slowly progress the absolute load, the total volume. Volume is repetitions times weight, right, for training tonnage. The range of motion used, right, to find the amount that gives us no irritation or a little bit of irritation, and then recovery from symptoms, I'd say within 24 to 48 hours. Right?
Usually what I'll tell people, so ideally, if we can increase your tolerance to exercise and keep it absolutely pain-free, that would be the preferred route that we go. However, sometimes what's necessary is that graded exposure where we actually do have to recreate a little bit of symptoms. And so with that, the general guideline that I'll typically give people, it's okay to experience pain while you're doing it, as long as that pain is short-lived and doesn't linger for longer than 20 minutes.
Yep.
Usually I tend to start with that first. And then if we're sticking to that guideline and we're still not getting the changes that we want or
Yep.
the improvements that we want, then I'll be like, let's try and provoke those symptoms. And I'm okay if it lingers for 24 to 48 hours. But as long as you go back to baseline symptom-wise, where you're pain-free again after that time frame, then we know that we didn't cause any additional damage to any tissue or flare things up at all.
Let's call that green light loading. So we can use the traffic light analogy to help us to understand where we're at in that graded exposure continuum.
Mm-hmm.
All right. Green light loading would be, I've done something, I have no pain, right? I'm good to keep going, right? You're getting no signal.
Or if you're in pain and it makes your pain better, that's a green light as well.
Yes, absolutely, right? I would say that's a green light. That means we can probably continue to do that level of activity safely.
You just keep doing it until it no longer gives us any benefit.
I would say that a yellow light would be, I've done something, I have some irritation, and then I go back to my non-painful baseline from that within that 20-minute time. To me, that yellow would be like, I've done something, I have some irritation, I'm back to my baseline before I did that irritating factor
You didn't
within a reasonable time frame.
The pain isn't
Right.
any worse, and your range of motion didn't suffer because of it either. So it could either be either the symptoms stay the same or your range of motion stays the same as well. That would be a yellow light.
Let's use lower back pain to give it some context, right? I did a deadlift from blocks, right? I had a little bit of irritation, but after the deadlift, I was able to bend over, touch my toes comfortably. I could lean back and do a back bend comfortably. I didn't feel like it made me lose the ability to move freely.
Exactly.
Right.
Yep. So that would be a yellow light. And honestly,
I think
for graded exposure, we essentially want to live in that yellow light
Yeah.
area.
If we're only in the green, we're staying within what's called your envelope of function, which is the current amount of activity and stress your body can tolerate safely, right?
Now,
Graded-
and that's if you have an actively painful issue that maybe isn't chronic at this point, and it hasn't reached chronic yet. It's probably more acute, it's newer, and you're walking in to work with us and you're in pain in that moment.
Yep.
We're going to start chasing green lights first.
Yep.
And then once we exhaust the green lights but you're able to tolerate more through exercise, then we're more likely going to be living in that yellow, and it's going to require that graded exposure.
Absolutely. We should define a red light.
So red lights. So let's say you do come in and you have 5 out of 10 low back pain. There's a few ways to identify a red light. It's either after you do an exercise, the intensity of your pain gets worse. So if you came in at a 5, you did that exercise, and now it's a 7, and it stays a 7, that's a red light. You did too much of something, or you did just the wrong exercise for you. That's a red light. You have to stop what you're doing with that and either just avoid that for now or do something else, or change the loading parameters or something like that. And that's honestly where working with Vital becomes super useful. Is you don't have to, we take out the guesswork and we are able to identify what traffic light response you have. So that's the first sign of a red light, is the intensity worsens or gets higher. Another sign of a red light response is you do an exercise, and then after we retest your range of motion, it gets worse. So you lost range of motion. That's another sign that you had an unfavorable response to an exercise. There's one other red light response that's possible, and that's called peripheralization. And this is specifically for spine issues that can refer pain into either your arm or your leg. So if we're using that low back pain example, if you had pain just in your back, you do an exercise, and then once you're done, that pain has moved, and it is now either it has migrated from the low back, and now you're feeling it. Maybe you might not even feel it in the low back at all. Now it's in the butt, or it was in the back and now it's additionally in the butt, or it could even travel further into the hamstring, into the calf, into the foot. So when symptoms move further away from the spine into the periphery, that's peripheralization. That's a bad thing. That is a red light. That means that you did either too much of something, you did the wrong exercise. You need to stop what you're doing, change what you're doing, because what you're doing is not getting the outcome that we're looking for.
Yep, absolutely.
And then the opposite of that is of peripheralization is centralization. So that would be a green light sign. So let's say you had the sciatica symptoms and it's all the way into the foot. If you do an exercise and then once you come out of it, you're like, oh, the pain was in my foot, now it's in my calf. You do 10 more of whatever exercise. It was in my calf, now it's in my hamstring. You do 10 more, now it's in my butt. You do 10 more. Okay, now it's in the middle of my spine. So symptoms move from further away from the spine towards the center. That's centralization. That's a good thing. That means what you're doing is helping keep doing it until we stop getting that good response.
Yep, absolutely. 2 other examples of when pain's not useful, or how pain can be present even when your injury is healed. Phantom limb pain is a situation where typically you had some kind of significant injury to a limb, like hand, leg, and that got amputated. There's no more receptors at the local level because they're physically removed from your body, but people still feel pain gets in their arm.
As if it were still there.
Or in their foot that got amputated. It's still there. There's no injury present because there's no anatomy, but your brain regions that light up from activity say that there's a portion right here that corresponds with me feeling stuff in my hand. I lose my hand. Your brain will actually change itself so that those sensations are now wired with the sensations of my elbow, which is a little bit behind that part in my premotor cortex.
It's been a while since I've studied
Don't
the brain.
ask me what specific region of the brain that is, right? But that's an example of a change in your nervous system being your brain that is causing you to still feel pain even though there's not an injury, right? This is a little out of sequence, but I thought that's a great example of how you can have pain and there's no injury, right? And there's therapy you can do for that.
Therapy.
Mirror therapy is one of the most commonly used ones, right? There's some other kinds of desensitization techniques for it. Graded motor imagery is another one. So there are some non-movement and exercise things that can be done.
It's think of it like exercise for your
persistent
brain.
pain. I think Adrian Liu has a lot of stuff on it. Why Do I Hurt by Adrian Liu is super useful, and it's something I will sometimes give to patients who I think there's a bit more to their situation than just a movement or an exercise thing alone. That can really help you identify some of the other things that can cause you to have persistent pain.
Cool. So if you're interested in learning more, definitely check that book out.
Yep.
I think that was a pretty solid talk on pain and when it is useful, when it's not useful. And I think we gave a pretty good description of how to use the traffic light signals to figure out if your pain is something that you should pay attention to or maybe not so much. So thanks for tuning in to episode 3 of Vital Conversations.
Yep.
And stay tuned for the next one.
If you've ever had the question of have I done too much, that's what we're here to tell you. All right, that's what we help you always have the answer to that question.
There it is.